Hello, and welcome to Continuing to Provide Quality Mental Health Care Remotely During COVID-19. A few housekeeping items before we begin. Today's webinar is being recorded, and the recording and slides will be emailed to all participants and registrants. We do not offer CEUs. However, there will be information at the end regarding how to receive a certificate of attendance. Today's presenter is Shiri Sadeh-Sharvit, a clinical psychologist and the Associate Director for Training at Palo Alto University Center for M2 Health in California. She also serves as the Chief Clinical Officer at Elios Health, a startup company in the digital healthcare space. Dr. Sadeh-Sharvit received research funding to conduct intervention studies on family and parent-based interventions, as well as digitally delivered programs. Her clinical and research interests include incorporating technology in mental health care, eating disorders from infancy throughout the life cycle, and clinical training. She co-authored the book, Parents with Eating Disorders, a treatment guide published by Routledge. With that, I'm going to turn it over for today's presentation.
Hello, everyone, and thank you for joining us. My name is Dr. Shiri Sharvit. I want to thank Ms. Whitney Ball from Mental Health America for the invitation to present today. And I also am very grateful and appreciative of Ms. Madeline Halpern's help in coordinating the event today. I will speak with you today about harnessing the power of technology in your clinical practice and continuing to provide quality mental health care remotely during COVID. The goal of the webinar is to present structure, support, and resources that will help you continue incorporating digital tools and teletherapy in your work while strengthening the therapeutic alliance and improving your clients' outcomes. I will present for about 50 minutes, and then we'll have time for Q&A. These are my disclosures. Oops. See that it's working. Okay, so these are my disclosures. Let me see, I have some issues with my arrows. Okay, but the issue with the arrows happens, or any other digital glitches happens every time I teach about technology. So here you go. Just to give a mental map quickly on what I'm going to cover today, talk about how the pandemic has affected your clients and my clients, talk about telepsychology, self-help apps and guided self-help programs, how to talk about social media use with your clients, and of course I will review very briefly some safety and privacy considerations. Okay, Ms. Halpern already introduced me. I'm a licensed clinical child psychologist. I've been an active psychologist in the past 20 years, received research grants to conduct studies both on face-to-face interventions and digitally delivered interventions. And of course, I'm still practicing these days with many clients, mostly with eating disorders. Okay, so as clinicians, we encourage our clients to adapt to changing realities and evaluate the realistic options before acting. In the past few months since the coronavirus outbreak, it has been clear that us clinicians have also needed to modify our strategies and procedures. This webinar is designed to provide you knowledge and tools to add more digital tools to your practice, and I'm going also to present some of the considerations you might want to address prior to offering digital services to clients. We know that human interactions and relationships are no longer limited to the physical constraints of face-to-face interactions. Digital tools have been introduced to therapist toolkit prior to the pandemic, but now they're a staple in everyone's toolkit. But there is some gap between what clients expect and what we provide. Most therapists have been primarily trained in assessing and treating their clients in face-to-face settings. But in real life, individuals are typically in close proximity to their phone, using it for work, interpersonal connection, and searching for information they deem as important or recording this information. Fortunately, many clients are now empowered and educated about their treatment options and the fact that many services are now available online. Dr. Eric Topol wrote already in 2014 in his book, The Patient Will See You Now, that patients are knowledgeable about their condition and how best to treat it prior to entering our office. They also expect technology integrated in their care. In clinical practice in general, not necessarily mental health care, consumer demand for online clinical services has been growing faster than the professional response. Presently, expectations for health providers' availability are higher than ever before, and some of the services cannot be provided in person anymore. Most individuals also do not understand why the connection with the therapist cannot be ongoing throughout the week, and why their mental health providers expect them to hold off sharing information they view as important until the next session. And these are things that are now a new part of our practice. But are we social distancing or distance socializing? Our clients now need us more than ever before due to financial concerns, increased stress and trauma at home, lack of access to healthy coping mechanisms, exacerbation of existing psychopathological symptoms because they're more home, negative media messages about productivity and self-improvement, and also greater use of social media and detrimental social comparisons. So in addition to all of the issues they have been dealing with before, now they need a few more, a bit of additional support, as I'll review now. So how is treatment affected by COVID, as we've all experienced? Issues such as the pandemic, the need to be in quarantine or isolate, being socially distanced are part of our reality in the next month. And we clinicians need to adapt our thinking to understand that teletherapy is not a quick fix anymore, but is an ongoing treatment delivery method, and in most cases, the only modality that is safe and feasible. So if we worked with clients in the past and in person, and every now and then met with them online if they were on a vacation or something about scheduling didn't work out, now this is the only means of treatment that is available to the majority of clients, and this means that we need to change our thinking. Digital tools can make therapy more efficient, more effective, and I hope that also more enjoyable, as I will review today. It can ease our communication, scheduling, help with assessment and self-monitoring, provide more psychoeducation, provide support between sessions. I will review shortly how our clients need more support between sessions these days, or at least the vast majority of them. meetings can supplement the in-person or face-to-face sessions to clients in a hybrid model. They can address important issues that may not be the therapist's major focus or area of expertise. For instance, I routinely prescribe self-help apps from reputable sources such as the VA for sleep, healthy exercise, weight management, etc. We can use teletherapy now to fill slots. And this, as many of you have noticed, probably has made scheduling easier. And there could be more continuity of care. Have you, most of you have probably noticed, teletherapy can provide many benefits to clients mostly with increasing access. Clients have increased access to care if they have some physical, medical, or mobility disabilities. We can treat and serve individuals in geographic areas, rural areas with few mental health resources. We can provide therapy in native language, for instance, sign language, therapy for individuals who are unable or have difficulty attending therapy on site, who have been underserved so far, for instance, those with PTSD or agoraphobia, and of course, providing care and continuity of care while clients are traveling, or if they're moving to another place where their current provider is still licensed. We saw that recently with students going back to their home state, and many of us have had the opportunity and received the permission from local licensing boards to continue providing care to clients who needed us most at that time. But teletherapy can also provide, teletherapy can provide many benefits to client. Okay, let me see. I'm sorry. Okay, teletherapy can provide many benefits to clinicians as well. We mentioned flexible scheduling. You can address a more consumer demand and provide more convenient time slots, fill missed sessions, or have new business opportunities. And there is growing empirical evidence as to its effectiveness and cost benefit. If I had delivered this workshop, as I've done many times in the past, before March 15, I would need probably to spend some decent time on convincing you, or at least offering the opportunity and the option that therapeutic relationship is not different in technology facilitated care. But I assume that most of you just have had to deal with it and provide care with whatever capacity that you could and with whatever tools were available for you, either via video and web conferencing, or over the telephone, or using the mail, whatever worked for your clients. But research, even before the pandemic, has indicated that the impact on the therapist-client relationship is minimal, if any. Research suggests that client ratings of therapeutic alliance, when they're working with clinicians that incorporate internet-based interventions, are high. And therapeutic alliance were roughly equivalent to ratings of alliance found in studies of face-to-face therapy. Okay. So I'd like to review a bit the challenges that we're experiencing these days. One of the key challenges is the issue of boundaries, especially in ongoing remote treatment. As you've experienced, most likely both the clients and the therapist's home environment are exposed. We can hardly control our pets. We can hardly control our family members speaking. Privacy may be compromised. I'm usually less worried about my own privacy, but I am worried about clients speaking and a family member or a partner or a roommate eavesdropping. Sometimes people live in really small apartments, so other members of or people living in the same house can hear them unintentionally. Sometimes the eavesdropping is intentional and their privacy is compromised. I found that I always ask, and it's helpful to ask at the beginning of every session, and especially if the client starts talking about issues that could be explosive. I'm asking about whether it's okay to talk about these things right now. Do you feel that you have privacy at the moment? Since there have been some incidents where other people have commented. Sometimes it's helpful to call other family members. Sometimes you can incorporate the entire family in the session for specific exposure, especially if we're working with a teen. I'm working with many adolescent clients with eating disorders, and it's very helpful for me that parents are there and can help monitor their meals and can help participate actively in the meetings themselves and help with weighing and other interventions that we're doing for clients with eating disorders. But it is important to remember that privacy may be compromised. You've all by now know to look at your background and see what information about you the client is exposed to. You can also learn a lot about the client's home environment and help them really work through some of the issues, such as organizing their learning environment, for instance. Another recent phenomena is Zoom fatigue. This is a tweet that I wrote on May 1st, describing my own experiences with Zoom fatigue, feeling that there is sedentary lifestyle unless I decide to exercise in a very busy day. I can get only maybe 1,000 steps, which is obviously unhealthy. Screen time and blue light exposure both exceed medical recommendations. Many of my colleagues have been using blue light glasses with some success. And what I found also, that there is no downtime between online meetings and home activities. So in the clinic, when I work in a group settings, and when I escort a client out and say goodbye, I can sometimes talk with the receptionist, talk with one of my colleagues, check in on people, express some of my emotions and thoughts following a meeting, and have some time for downtime. Even walking from work home or driving is some time where you can collect yourself and recompose. But I realized that when I finish the clinic and I go outside my office, I'm immediately in other roles, such as mom or a spouse, or caring for my pet, etc. And there is almost no time for, no opportunity for downtime. So you should be mindful about it. Schedule some breaks, stretches, change of scenery. Today in the East Coast, it's not a good day to talk about working outside, but if you're able, when the weather is better, to work from a space outside with privacy, that would be helpful. for your mental health, and of course time away from your computer or phone, or just taking a few minutes to collect yourself and recompose before you open your home office door and engage with the other family members. So let's talk about some guidelines for stress-reduced practice. We already, I'm sure everyone has mastered how to ensure confidentiality, privacy, receiving informed consent. It's important to know the local licensing requirements. Now many patients or clients are traveling across the state, and they're surprised to know that many mental health clinicians cannot treat them. Of course, always use encrypted services such as Zoom, Doxy, Rebound, VC, and many, many more. Educate the client about being in the right location where it's private. I've taken numerous calls with clients where they sit in their car or even in their truck because they were unsure that other place will be private. Talk about bandwidth and address connection issues. What happens if the call connects? Do you continue on the phone? Do you decide to reschedule, etc.? Help ensure client safety. Make sure that they don't have access to any self-harm tools, and always know both the details of an emergency contact that is whose name appears on informed consent, and also the local police. So you can ask the client for the number of the local police and the local firefighter department. And it's good to know that in advance so that you won't need to call 911 and start wondering where the client is exactly. If clients are traveling and you're licensed to treat them where they travel, of course, it's helpful to know the local police number and their vacation destination. And as I'm sure everyone has done already, plan your office background, attire, background noises, and of course, internet speed, which is helpful. I've realized these days that people need even more connection than in the past, and many of us do not have access to our typical support system, or at least not in the same intensity. And virtual group treatments have been mushrooming. I'm hearing about it a lot from supervisees, groups for individuals with eating disorders. I'm also leading PHP and IOP groups with an organization I work with, and I've heard about virtual groups for teens, for the elderly, for people with autism, etc. And I'd like to share some considerations for making treatment more seamless. Define a virtual waiting room and admit participants only after verifying their location and emergency contact number. Mandate that video and audio be turned on. With some of our adolescent clients, they have been programmed during remote school to have their phone or their audio muted. For treatment, it's a bit different, and I need to remind them repeatedly that here we encourage them to have their video turned on. Ask clients to correct the name appearing on their video if necessary, so that no identifying information such as last name appears. I offer many of my clients to hide their self-view so that they are not distracted by how they look. I also hide my self-view immediately when I start a session, just like in real life when I don't look at my hair and how I look to the other person. Be clear about confidentiality, no picture taking, sitting in a private location to protect other participants' privacy, etc. I found that sending handouts prior to the session is very helpful. I often share screen to visualize content. And if possible, have another colleague contact participants who logged out. Unfortunately, this is the case very often, that people disappear or the content was too intense for them, or they don't want to be called out, etc. And it's good to have another colleague that could contact them and not just email them during the session. Additional challenges with ongoing remote treatment during the pandemic. This is based on a paper that a group of colleagues and I recently published. We see many changes in our clients. First, the client's world may become more limited, not much to talk about, I have nothing to say, etc., nothing much, etc. These are phrases that I hear a lot. People experience fewer mental, social, and cognitive stimuli. They describe being bored. They describe engaging in self-harm or abusing materials because they're feeling bored. So, and opportunities for behavioral activation are limited. There is pressure that has been expressed in social media, for instance, to be productive, to lose weight. While in quarantine, many of my clients have heard about COVID-19, as in freshman 15. When you're expected to lose weight or at least not gain weight, health anxiety increases for obvious reasons. Many clients experience financial or food insecurity. There is unfortunately increased the potential for domestic violence, for abuse and trauma. Many times people return home to family environments that could be toxic. And clients often need more support than the designated session time, as I'll describe right now. So I'm going to give a de-identified case example of a client with whom we worked, and their data we collected in Ilios as part of a case report that is now in review for publication. This was a young man with very age-appropriate concerns, mostly about the transition to their adult life. Baseline assessments, PHQ-9, a measure of depression, was 18, GAD-7, a measure of anxiety, were 15, indicating that his depression and anxiety were both in the severe range. Clients started improving in treatment, but then COVID happened. So we collect data after each session. We send a text message with very few items, 16 items on a Likert scale, that the client can complete. You see here that client's symptoms started reducing, which means that he's improving. But then in session 4, client was furloughed due to COVID, and you see a spark, an increase in both depression and anxiety, which is very predictable and understandable. But something also changed in the session and in the way that the client was using treatment. So it's clear that client's self-report was has changed due to COVID-related events, life events, but also the way that they were utilizing treatment has changed as well. So at Ilios, we also record sessions, of course, with the consent of clients, and we utilize some of the information from the conversation itself to summarize, analyze, and visualize it to the therapist, what we saw here is that client was speaking most of the session. 85% of the time it was the client speaking. The therapist was speaking mostly 15% of the time, which means that the client has a lot of their mind. Maybe they need a lot of support, they need to vent, but then they maybe not be able to utilize the therapist's wisdom and expertise in making changes. Also, we noticed that the patient was speaking much faster than what they've done in session 2 and session 9. And also that the therapist was also speaking a bit slower, trying to help the client maybe ease down, maybe take some time to think, but they were not able to. And this led us to some really interesting insights about what clients really need from us and how to make treatment effective. And you know, the 50-minute hour when it's weekly may not be really sufficient to our clients right now. And what I suggest is we can add digital tools to complement our digital practice. And digital tools can extend your typical routine care and preferred practices. I listed in this slide a few advantages to using text and email messages between sessions as needed, guided self-help apps and online programs, and prescribing behavioral activation to your clients using digital tools such as their Fitbit or another pedometer or sensor. The benefits include streamlined communications, shared decision-making, clients self-monitoring and self-management in real time. Adding these services and platforms that I'll review shortly likely increases the therapeutic alliance, partly by creating a less threatening venue for raising sensitive or potentially embarrassing questions and expressing emotionally charged content. Text messages also may increase provider efficiency and improve the quality and relevance of the services that we deliver. So consider suggesting to your clients the following services, such as online program and smartphone apps for self-monitoring from reputable sources. I like all the apps coming from the VA because they're embedded in research and they're at no cost. For instance, I have a young woman with whom I've been working for a while. Now she started having sleep problems. We're using the app by the VA, CBTI Coach, really terrific app. And I've listed some of the resources later in the slide deck. There are self-help programs and therapeutic chatbots as well. And of course, support groups. Also review with your clients their social media use, which has been problematic to many of our clients and for us as well. But before we start engaging with them with additional tools, I would set up mutual expectations. What I say something along the following lines: I'm very happy that we're starting to work together, and I believe that I can help you with the issues you've raised. I wanted to let you know that this treatment is effective most when important issues are discussed in our meetings. I'm unable to respond to phone calls and messages immediately. I will do my best to respond within 24 hours, but if you're concerned about your safety, you should go to the nearest ER or call 911. This is a very good way of setting up mutual expectations. And of course, for non-urgent matters, I suggest clients email me. And that's because I'm obligated to save all communications in their medical record, and it's much easier for me, specifically with email. So in terms of self-monitoring apps and online assessments, they can include prompts for real-time monitoring. They can be automatically graphed and analyzed. They can be sent to the therapist, linked to mobile devices, include visual information, such as photos, and be part of an interactive program. Self-monitoring is a common component of behavioral treatment. Most treatments and interventions are based on the client assessing whether how severe the problem is and whether treatment is helpful. And you don't have to use really sophisticated apps. I'm trying to move to the next page. Okay, you don't have to use sophisticated, whoops. Okay, thanks. Thanks, Madeline. You're the best. You don't have to use really sophisticated apps. The issue is recording and recording in real time. You can use your phone notes app, ask the client to send email, or of course, send you a text messages if that's okay with you and with the way that you practice. But if you incorporate messaging, I'd like to discuss the do's and don'ts of messaging in your clinical practice. We educate clients about privacy and confidentiality, clarify our expectations for our availability, response time, urgency. It's important to save a copy of text in the client's permanent health record, add text and email messages to informed consent. And it's also very helpful to create semi-structured text for challenging situations. When you do respond to email and text messages from clients, it's important to be succinct, reiterate information and skills that your client has already mastered. So if mastery visualization help them, it's not the right time to start working with them on more sophisticated tools. Maintain a professional tone, as these texts can always be screenshotted and sent to another person and can be distorted and twisted. Online correspondence is best when it's skewed a bit to the positive side. So I keep a more positive emotional tone when possible with my clients when I correspond with them via email or text, as I don't have access to any of the gestures or softer tone or cynicism, and no, emojis are not the right thing to include. Reply from an email account that is associated with your professional role, and of course avoid writing unnecessary information. I always write very general titles that no one could relate to treatment, such as checking in, catching up, about your inquiry, etc., so that anyone looking at the client's phone or email won't know what it's about. A common question is, what happens to the boundaries? I'm working all around the clock, 7 days a week. These email and text communications require additional expenditure of time, and who's going to pay for that? These are valid questions, and we've all experienced them in the past couple of months. Boundaries can indeed be crossed when the ground rules for using text communications are not articulated up front. This is why I tell my clients that I will be able to respond within 24 hours. Even though, let's face it, I check my email every 5 minutes. There is data to show, at least from training of trainees in mental health context, that the number of text and email messages reduces over time. This has been my experience as well. but always practice in concert with your personal values and preferences. And if texting with clients or emailing them, receiving emails from them is not within your comfort zone, then please don't do that. One interesting study that I did want to share. Let me go back to the previous slide. A text-based maintenance program following hospital discharge. Patients that were discharged from residential treatment were asked to send an email to their a text message to their therapist once a week for 16 weeks post-discharge, and the therapist responded in one text message that was adapted to the ex-patient's message. The patients receiving text had less eating disorder symptoms and better functioning than controls. I think that we all care deeply about our clients, and when they finish treatment, if I had known that my clients would be able to persevere in their recovery and maintain treatment momentum with only one text from me or one text correspondence over 4 months, I would gladly do that at no cost. And it's important to remember that this is also a valid way to make sure that treatment effects are continued for clients. Really quick to cover social media. We know it's likely to having an impact, perhaps negative. I'm not going to review all the terrible things that happen with social media. We know that from research in 2016, at least, that clients may not be assessing how their clients are using or abusing social media. Only 20% of clients reported that the therapist asked them about the impact of Facebook on symptoms. You can definitely see it's a study from 2016. Who uses Facebook anymore? People now are on Instagram or TikTok, and I'm wondering if you are asking your clients about Instagram or TikTok. I've been asking about Instagram, but I have to say that I haven't been asking about TikTok that much. It's also an opportunity to connect and, oops, I'm sorry. Social media might have benefits in opportunity to connect, and we can prescribe online support groups when we know that it's from a reputable source. And of course, we need to monitor our clients' use and their experience. General principles in using social media that I'd like you to educate your clients on are to use built-in apps for monitoring screen time and activity. Consider being more authentic on social media. Do not use any social media and block access to these platforms after 9 p.m. A very solid recommendation. And of course, mute or unfollow triggering accounts. Really briefly, I'd like to talk about risk for privacy. That's also part of providing quality mental health care. The main risk is from unprotected phone or computer, either ours or our clients. Here's a quick checklist for security. Enable automatic log off from all of your services. Turn off your notifications on your locked screen. I'll show you how to do that in the next slide. Enable remote wipe of your phone or laptop if you forget them somewhere. And update your non-corona virus protection so that your client's information is protected. Make sure to turn off or hide text messages previews, or otherwise clients' messages may pop up. Here's a quick fix how to do it either on iPhone or on Android. Then you do not see who's the person texting and you don't see the content of the text. And of course, if you're confused and unsure how to go about that, ask any teenager. They'll be willing to help you, or they will be able to help you. I'm not sure if they will be willing to do it, but I'm sure you can navigate some kind of resolution. One additional question that at the moment feels like science fiction, but should my clinic remain virtual post-COVID? Humans are social creatures, and the need for human face-to-face connection, in my opinion, will likely increase after this emergency situation is resolved. But your clients and you may feel that commuting to treatment becomes a hassle, and consider a hybrid model where remote and in-person treatments are integrated. Finally, if we would like to summarize how to enhance treatment impact and the therapeutic alliance in remote therapy and continuing to provide quality healthcare, I think about how you address Zoom fatigue. A sec. How you address Zoom fatigue. Be mindful of behavioral activation to clients with lower stimuli, more pleasurable activities. Consider integrating family members in the therapeutic process. Reinforce the client's available resources, their brainstorming, their own troubleshooting. Prescribe support groups, social distancing activities, volunteering, etc., and complement treatment with apps and services from reputable sources. Finally, before we open the meeting for questions, I made here a list of a few resources that you could use. Maybe Madeline can help me with moving to the next page. I apologize for that. Okay, thank you. Maybe skip to the next page. This is just a summary about core principles, follow usual ethical standards, be mindful of privacy, where digital information goes, where it's stored, ask your clients repeatedly about their experience, and of course, explore new tools and have fun. And finally, the last slide with resources, APA telehealth guidance by state during COVID, general telehealth guidelines from 2013, and resources on the Mental Health America website and on the Center for Mobile Mental Health at Palo Alto University. And now I'd be happy to answer some questions if there are any. Okay, so I'm going, so there are a few open questions that I'd like to address. The first question was, is there a list of the digital tools which addresses issues that are not a provider's area of expertise? I recommend you go to the VA, that's the Veteran Administration app list or app store, and you can find all the apps there. It's called VA App Store, VA Mobile, Veteran Affairs. These are terrific apps, and as I said, they're embedded in research, and I highly recommend them. Any research on phone-only encounters? Well, you know, this entire topic of remote treatment has developed from phone research already in the 1990s, and where people receive, excuse me, when they received, for instance, support groups for cancer recovery and mental health problems. And research has been very supportive and very positive. And so these treatments are still effective. Most virtual connectivity tools are not free or require a membership. Are there any telehealth type programs which do not cost much and can be used via phone or tablet? I'm not sure. I think that for Zoom you can have, but it's not a HIPAA compliant one. Yeah, that's a problem. I think there is some additional cost if you can, that unfortunately our clients will pay unless the insurance companies would be able to support them in receiving treatment. At the moment, I'm not sure that except for telephone, there's anything that is HIPAA compliant and free. When another question, when clients are traveling out of state but keep their telehealth appointments via Zoom, should we not be delivering services if we are only licensed in the state where we are providing services and not in the state where the client is located? Yes, yes, yes. You should not, or no, or I'm not sure if yes or no, but the answer is don't do that. Practice only within state lines and where you are licensed. Even if the client goes, I practice in Maryland. Even if the client goes to DC for just a visit and they want to take the call from their car, no, they need to be physically present in the Maryland. So even on vacation, you can treat your clients even if it's for one time. Another question, in Ohio, many insurance companies are now requiring clients' location and or address be documented in engagement note. Yeah, that is correct. Have you taken any steps to differentiate what care or services can be over phone, audio only, and what requires video? I think that video is preferred because it mimics more the in-person meeting. And I personally prefer it, but if your clients are only able to speak over the phone, this is definitely better than not receiving treatment. So access is the key issue here. Could you speak more about mandating video being turned on for virtual groups? Yes. As I said, video and audio must be turned on. That's part of the agreement and the contract prior to beginning treatment. I need to see clients and need to make sure that they're not engaging in any self-harm, not abusing materials. And also, if any of you have teenagers or kids who've been homeschooled or remote schooling recently, you know that when a few people's video is turned off, also other people tend to disengage, and it's not good for the group. TikTok isn't HIPAA compliant, but our youth and age, we use Instagram. I was referring to social media not as a means of communication, but a means of an issue that you need to address with your clients. Yeah, but TikTok or any of these services are not HIPAA compliant. Due to the current pandemic, another question, how do you ask about social media engagement while being mindful that some clients may be using it to supplement their usual in-person social activities? That's a terrific question. I ask about the client's experience. So for me, it's a no-brainer because I work with many individuals with eating disorders. So I ask, do you feel better about your body after browsing your social media feeds? After 5 minutes on Instagram or TikTok, although I don't ask about TikTok that often, but after 5 minutes of Instagram, do you feel better or worse about your eating habits? People know very quickly the answer to that. So the idea is not, to log out of social media and delete accounts. The idea is really to curate the right feed for you, maybe unfollow or mute accounts that are triggering, maybe not consider not engaging later times of the day. Another question is, do you know if there's any data regarding the effectiveness of phone-only therapy? As I mentioned, there has been data starting the 1990s about effectiveness and efficacy of phone-only services. Please, if your clients, if that's the only means of communication they're able to have, by all means, continue providing care through these platforms. What type of volunteering have you found possible during COVID distancing? So it's a bit tricky for clients with eating disorders because they're considered a risk factor because they're immunocompromised. But one of my clients, she prepared masks at home. Another client volunteered in a food bank, and she was not immunocompromised. And other people have been tutoring or even playing chess with younger family members, like nephews or kids of friends. And that has been very rewarding and a very positive behavioral activation activity for them. But have you had trouble setting boundaries with digital communication? If so, how have you handled it? My signature line indicates that I'm unable to provide services for emergency issues, and that I respond within 24 hours. After receiving the first response for me like that, clients have been mostly able to communicate within boundaries. In general, I haven't had many issues with that. Can you go over some of the apps that you recommend to add to our practice for ourselves or for our clients? Yes. So as I said, everything that's coming out of the VA, I prescribe to my clients the apps of Calm or Headspace. First 10 sessions are free. So, you can, and you have so much information online for mindfulness and other interventions. And interestingly, also Headspace provides no cost platform for mental health clinicians. So we just need to send them your NPI number and you can get access for free.
Are you aware of if the VA apps or of any other apps that are in languages other than English?
That's
particularly Spanish?
That's terrific question. Let me pull it up. Mental health apps on the VA App Store. Let me see. Unfortunately, I do not see any that are not in English. That's a very good point.
And for those who are interested in getting a certificate of attendance, please email mhalpern@mhanational.org. I'll send that out in the chat box as well.
Thank you, Madeline. Do you have a time to answer a few more questions?
Yeah, you have a couple minutes left.
Okay, thank you. So another question from another participant if I use any formalized screeners or checklists with my clients. Yes, I do. I use personally, and also we use in Elios as a company, both GAD-7 and PHQ-9. There are heavily researched, very strong, robust tools. The items and their scoring are available online. PHQ-9 and GAD-7, check them out and incorporate them in your practice. I highly recommend it. How authentic are the Zoom counseling sessions? Well, you know, I've been trained in originally in a psychodynamic school, so I can definitely say that even phenomena like projective identification do take place in Zoom counseling. I've done it for many years with clients in different functioning level and for different problems. When you use your clinical skills effectively and you create a strong therapeutic alliance and there's authenticity, it will exist also via Zoom. You can have clients that will meet you in your clinic 3 times a week and they won't open up about something. That is important. So I think it's more about clinical skills. I admit that it's not the same connection, and I also miss going back to the office and seeing my clients, but I feel that Zoom counseling is better than, it is very, of course it's better than nothing because that's what's available for us right now, but it's also a very potent tool to provide care.
Well, that's all the time we have for today. So thank you very much for a engaging presentation, and thank you to all of the attendees. Again, for a certificate of attendance, please email mhalpern@mhanational.org.